I'm really pleased at this point to introduce Jeremy Horwood. So Jeremy is Associate Professor in Social Sciences and Health, and Jeremy is going to be giving us an overview of the Applied Research Collaboration West's COVID-19 research portfolio, so building up that evidence base we talked about. And as I mentioned earlier, please do keep on putting those questions into the chat, and we look forward to hearing from Jeremy now. Thanks.
Thanks, Ollie. Okay, yes, so as Ollie said, so I work for ARC West, where I lead the Behavioural and Qualitative team. And going to the next slide. For those that don't know about ARCs, so we're funded by the National Institute for Health Research, and there's 15 around the country. And our aim is to support applied health and care research. And that's research that's got a national and international impact. And by applied health research, I'm saying research that makes a difference on the ground. If you go to the next slide. So our patch is bigger than Bristol. So we go all the way up to Gloucester, we go across to Swindon, and we go down to Weston-super-Mare. So we've got 2 SDPs and 1 integrated care system within this patch that we're working with. If you go to the next slide. And we are a collaboration. So we're a collaboration with all the acute trusts in the region, all the CCGs, all the local authorities, and all the 4 universities as well. And if you go to the next slide. And with all of those partnerships, there's a lot of partnerships to deal with. We're working on 4 different work streams in terms of our research. So public health and prevention, mental health, integrated and optimal care, and healthier childhoods. And we're working with the STPs and integrated care systems to find out their priorities under these 4 themes. And within the ARC, there's then 4 different methodological themes. So we've got the applied data science, so the DATSI people, the evidence, which is people who do systematic reviews, health economists, and the behavioural and qualitative, which is the team that I lead. And then throughout the pandemic, we've been doing a lot of COVID research. And this is really because our partners have come to us, especially at the very start, saying, we need some rapid evidence. So we set up this rapid evidence service where we called upon researchers from across Bath, Bristol and UE universities to do rapid systematic reviewing of looking at evidence out there, but also doing some number crunching on data as well. And all our reports are published on our website. I'll just give you a highlight of a couple that we did. Go to the next slide. So the first was we were asked by the Bristol City Council to look at the factors associated with the increased risk of COVID-19 for the BME communities. And this was before the Public Health England report came out. And we found that, it was a complex mixture. There's no one factor that could explain this disparity. So it's, to do with deprivation, with housing, location, occupation, comorbidities, and people's access to health services. And these
Jeremy,
yep.
Jeremy, I'm sorry to intrude, but I can't hear you very well.
Okay, I'll speak about
Sorry.
That's okay.
I'll switch myself off again.
Okay.
Thank you.
And these findings were taken up by the council and to do their COVID response. So if you go to the next slide. Another rapid review we did was from Gloucestershire CCG, and that was the impact of COVID on mental health outcomes. And from this, we found that healthcare workers are particularly at risk, but also those with existing health conditions, children and parents, COVID-19 patients, the bereaved, those with lower levels of education, those who perceive themselves at risk, and those in outbreak hotspots were particularly at risk. And our review said that basically we need to do more screening to find these people that are at risk, and then the use of online or remote resources could be useful in this situation. Next slide. Another study was conducted by UE colleagues, was a part not alone. And this was really to map what was happening during lockdown in terms of neighbourhood support. So they did a survey early on, and then they did some in-depth interviews, and then they did a later survey just when lockdown was sort of easing. If we go to the next slide. And what they found was at the start, you know, that community response was actually really good and things were done very quickly, usually quicker than voluntary or public agencies. And loads of support was provided, so food, medicine, as well as entertainment as well. And in Qualitative, we really magnified the fact that in more deprived neighbourhoods, more likely to report that people were being helped, and people with disabilities or reduced mobility were being helped by the community response. Later on with the interviews, we found out the response was usually being led by women, and there was a decreased and increased sense of belonging. So there may be people coming together, but also divisions, and the divisions around sort of gender and class lines. And also that there's the importance of building on this cultural capital, that, you know, people coming together as a real resource that could be used. And the later survey found that, you know, these connections were actually still carrying on, and people didn't want to go back. People really wanted to keep this, you know, the response that neighbourhoods had come together. There was some disquiet though, and sort of things seem to be breaking down a bit. Maybe a lack of solidarity, and maybe people's grievances about other people's behaviours as well. And a paper is being published, which the link is there, and you can follow them on Twitter as well. The next slide. Another study is Lucid B, and this was really to find out what's the experience of injecting drug users throughout the pandemic. And so interviews were done very early on in lockdown to find out the challenges that people were facing and how people were adapting to the new situation. And 4 rapid reports have been published on our ArcWest website. The next slide. So what they found the challenges were, well, people often were on the streets asking for money, and that was no longer possible with lockdown. That the boredom and isolation of lockdown may compound some mental health problems, and there was also reduced contact with services due to lockdown. And so this affected people's drug use. Some there was greater stability because of the efforts by the local drug agency to help people, whereas others there was increased use of drug use, maybe because of boredom, because of stress. Some reported there was a reduced purity in heroin, and also different use of drugs, so spice being used as well. Also in terms of the service adaptation, so changes in opioid substitute prescriptions. So some pharmacies, it was quite difficult to get these subscriptions because of lockdown, really affected things. But there was home delivery of needles and syringes and street outreach, which really helped people as well. Next slide. So another study we're involved in was Rhapsody, and this is looking at what changes were happening in primary care in GP practices throughout the lockdown. So we did 87 interviews with 20 practices of 4 different time points. And we also looked at patient record data to see what was happening as well. And we've produced 5 rapid reports, which are available on our website. Next slide. So what we found was there was a reduction in GP consultations around April, so by 17% on the previous year. By June, this had increased, but by July, it leveled off. And this initial drop in consultation was actually really important because it allowed GP practices to start doing remote consultations. And so a lot of new technology had to be installed in practices, and staff had to get used to this new technology. So 90% of GP consultations were done remotely in April, and that's compared to only 33% the year before, so a dramatic change. By July, this had dropped to about 85 because practices were lowering the threshold to see face-to-face consultations. And while GPs reported that they were coping well with the pandemic, towards the end of the interviews, they said they were coping less well. And there's real issues around face-to-face consultations requiring big infection control procedures, which takes time. Telephone consultations were sometimes seen as more complex. And also doing total triage, so everyone being triaged either by phone or online before seeing them was actually really draining. There's also issues around inequalities in terms of are people being digitally privileged if they can access online consultations over those that haven't got that sort of technology as well. Next slide. So that's the work that we've been doing. Now to think of some of the future work we're doing. So next slide. One of them is NHS checks, and this is looking at the health and well-being of NHS staff. And this has been done with 18 trusts around the country. And there's a baseline survey's already gone out, and there'll be another one at 3, 12, and 18 months. And this will really help with trust plans of how they're actually going to help their staff. Next slide. Another study is Octavia, and this is about looking at those treatment escalation conversations. So when someone's severely ill and you may be thinking about end-of-life care. And through the pandemic, there's been difficulties with this, especially with people having to do things remotely and with relatives not being around as well. So with this study, we're going to be interviewing senior decision makers around how these decisions are made and how they're communicated. And they'd also be doing some audio recording of these conversations as well to see what's happening there. And this will be used to provide training and guidance to help these conversations in a more sensitive and compassionate way. Next slide. Germ Defense is another study we're working on, and Germ Defense is a behavior change website that helps reduce infection in the home. And we're doing a national trial where we randomized all the GP practices in England, and 50% are sending it out in the next month and 50% sending it out later. And we'll see what difference it's had on infection rates. Next slide. And COMET is another study we're working on, and this is doing testing and tracing within schools. So testing whole schools so we can see where the infection, how the infection is spreading in schools. We'll also be looking at what can be done to prevent outbreaks in schools, so things like hand washing interventions, and also be exploring the mental health of pupils and staff as the schools go on as well. Next slide. Okay, so that's a whiz through our portfolio at the moment, but all these reports can be found on our website, which is here, which I'll put into the chat, and also you can follow us on Twitter as well.
Brilliant. Thank you, Jeremy. You've certainly been really busy, haven't you, you and your colleagues? So thanks for giving us that tour. That's been really helpful.
I'll just add our website into the chat now.
Perfect. Thank you. And we can take some questions later from Jeremy too. Okay. So I'm really pleased now to introduce Alison Llewellyn. So Alison is a project manager for the Chronic Pain Health Integration team and also a senior research fellow at the University of West of England. As we've been mentioning, it'd be great to have some questions coming in through the chat. We've got a few and look forward to some more. But for now, over to you, Ali. Thanks.
Thank you. Could you just move on to the next slide, please? Thank you. So, hello everyone. I'm really happy to be here this afternoon and pleased to have the opportunity to tell you very briefly about an electronic survey that we ran in the summer amongst the health professionals of the membership within our HIT, where we wanted to really find out about the impact of any changes they'd made to their services in response to the pandemic. Next slide, please. Thank you. So we ran the survey at the end of July and we received 16 responses representing 12 different pain services in our area and encompassing the full range of care providers. We asked questions about service changes and how these had been received. And as you might imagine, the majority of services reported having to very quickly implement some form of remote service, whether that was telephone support or online individual or group video conferencing. And Stephen also already mentioned today that he was involved in some Zoom physiotherapy. So that's just one example. And for the purposes today, I've looked at the data we received and I've summarised the preliminary findings just in relation to how respondents felt these new services either exacerbated or reduced health inequalities in terms of access to the care that was provided. New slide, please. So 15 of our 16 respondents said that they felt that either individuals or groups had been disadvantaged in some way by changes in service provision. And the risk factors for that, as Jeremy just mentioned, were primarily where patients had limited IT access. So there's sort of an IT privilege going on. It could be that they had lack of hardware, lack of equipment, or lack of IT skills, or indeed just poor broadband, which I know many of us have suffered with, and is often a problem in rural areas, for example. Also, it was reported that people for whom English wasn't their first language were considered to be disadvantaged because it was very difficult, certainly in the short term, to arrange for interpreters to be available in Zoom sessions, for example. Older people were found to be slightly disadvantaged sometimes because they might have hearing difficulties or lacked confidence with the tech. And for them, sometimes it was particularly difficult to engage remotely. It was also reported that people who had communication challenges, for example, if they had learning difficulties or dementia, they'd sometimes been quite anxious about IT use, particularly when it wasn't going smoothly. And I've experienced sort of glitches myself and know how difficult that can be sometimes. And one of our respondents also pointed out to us that their patients who had dyspraxia or dyslexia had found it hard to understand some of the exercises being taught remotely. So that certainly was a disadvantage for them. Lack of space or privacy within the home was sometimes problematic, particularly when taking part in virtual physio classes. And it was also found that sometimes people who had caring responsibilities, and for a lot of people at homeschooling this was the case, they had limited time really to engage with services being offered remotely. But just as Stephen mentioned earlier, there were also a number of advantages that were identified in terms of the service changes. So, for example, remote services were perceived as being convenient and flexible. Patients had often been better able to fit their appointments around their work commitments, or indeed around their fluctuating pain levels or their lack of energy at times during the day. Stephen also mentioned about reduced travel, and that was a really common theme within our data. So it was that not having to travel to appointments was really considered to benefit those who had reduced mobility or those whose pain was actually exacerbated by travelling and then leaving their home. It was also the case that respondents felt that in some occasions when they had to discuss perhaps sensitive psychosocial contributors to individuals' pain, they felt doing this remotely, they were often able to have more meaningful discussions as patients were more relaxed and less anxious talking to them from their own homes than having to come into a clinical setting. Our respondents also indicated that appointment attendances had improved. Plus the belief that when people were attending those appointments, when they were engaging in those remote activities, they had greater physical and psychological resources because they'd spent less effort in getting to the appointment in the first place. And again, that was something that Stephen mentioned earlier. So just to summarise, really, most of our respondents suggested that they or their patients would be really happy to see some form of remote service provision being carried forward. And that's indeed what Stephen mentioned is, we can't really unlearn what we've learned, and some of it is really important to hang on to. But what I think the feeling was that a sort of blended approach of online and face-to-face services going forwards would be useful. They felt that very much that would give patients choice in terms of what they could access and offer almost a more sort of personalised pain service, and that would be very beneficial for effective care going forwards. So as I mentioned, these are just the sort of preliminary results in a brief summary, but we'll be compiling a more detailed report. So you're always able to get in contact with us and we can share that with you. And I'll be happy to answer questions as we go through today's session. Thank you.
Thank you, Ali. That's really helpful to see how you've taken some of those things that Stephen was highlighting and built evidence around it in your service. Thank you. So as Ali just mentioned, it'd be great to have some questions if you wanted to add them into the chat. We've got a few already, which is great to see. I'm pleased now to welcome back Subitha Baghirathan. This time, Subitha, through your role as Physical Activities Coordinator at the Wellspring settlement. And you're going to talk a little bit about some of these issues we've been picking up here about digital inclusion and how to get people involved in new ways of delivering services. So over to you. Thanks, Subitha. Thank
you very much. Good afternoon, everybody. And I'm glad it's raining outside, so it's not distracting you from not listening, joining us, listening to the speakers. So I'm Subitha Baghirathan, and I have many different jobs, some of them even paid. And I'm here to talk about my role at Wellspring Settlement, which used to be known as Wellspring Healthy Living Centre until February, when we merged with Barton Hill Settlement. And my role there for the past year has been as our physical activities coordinator. Wellspring Healthy Living Centre was very much founded on the belief in social prescribing. So the majority of people we begin working with are based on GP referrals, although we're also open to people self-referring to us. Part of our social prescribing service is through one-to-one emotional sort of well-being, mental health support with a trained group of social prescribers. And the other part of the offer, we've very much stacked our chips with a belief in offering like arts therapy, but also physical activities. So our social prescribers can refer in-house to our services, but we also refer out to services or activities run by partners, whether that's kind of befriending services or thinking sort of walking groups run by other organisations in local parks and so on. So that was how we were running prior to lockdown. And Wellspring Healthy Living Centre, let people know, is based in Lawrence Hill. So it's an area, and we take referrals from GP surgeries based across central and east Bristol, which tend to be areas of quite high, what they would call deprivation. So for example, very high unemployment, sort of low levels of educational achievement, many people living with different health conditions. And there's very high numbers of Black, Asian, minority ethnic communities across the patches that we serve. So that's kind of how we were running up to the point of mid-March and lockdown. And we had a real focus on trying to improve the accessibility of the services we ran in-house. So for example, for our belly fit classes, we offered a free creche. So there was really high take up, for example, particularly from Somali mothers living in some of the local areas, for example, the flats in Barton Hill, because there was a free creche. And we made our activities either free or very low cost, so £1 as a drop-in. Then mid-March happened and lockdown happened. Some of our instructors were amazing and were very ICT savvy already, and immediately made an offer. So for example, with Belly Fit, Agnieszka offered to start running her classes via sort of live stream on Facebook. She already knew that most of the participants on her classes, she used to run 2 classes for us, I had already linked with her on Facebook, so she knew that most of them could attend those. However, the challenge was many of them were mothers, and you know, how to attend a class live when you had young children at home, and homeschooling was a different challenge. But she's managed to keep quite a cohort together and take on new referrals. But many of our other, well, all of our other activities completely stopped. Our social prescribing team was busier than ever, though, as you can imagine, with more and more GP referrals of people experiencing emotional well-being issues, mental ill health issues. I then was offered the opportunity very quickly, probably only about 2 weeks into lockdown, from Karen Lloyd, Karen Lloyd of Active Ageing Bristol, who I think is here today, and Isabel Jones from Alive Activities, whom I really need to thank, because they came to me and offered the chance to join with them on the consortium bid for a short-term pot of money made available from St Monica's Trust to trial virtual activities. My managers at Wellspring were really supportive and said, sort of, go for it. We've got no evidence base, but go for it, even though in many ways it was quite contrary to our ethos around accessibility, because we were worried about exacerbating digital exclusion. However, we wanted the chance to trial this. And we did. So from about mid-May, I managed a program over 12 weeks of Zoom activities. We went to some of our existing instructors. So for example, Caroline Stevens, who I think is here today, was running our chronic living with chronic pain program at Wellspring, and I gave support to that. So she started running sessions over Zoom, and then we started up a new partnership for Qigong, and we also went back to our singing for wellbeing instructor, and she started running sessions for us on Zoom. And the take up was absolutely fantastic, particularly for the physical activities sessions, the Qigong and living with chronic pain. We did have some participants who joined all 3 of them, which I hadn't expected. I'd say about 70% of our participants were new to Wellspring, so they were based on new GP referrals. So some people could self-refer, but I think not many people were really checking the Wellspring website because they assumed that we weren't running anything. So not many people sort of found out what we were running, but we had absolutely loads of referrals coming from the GP surgery. So that enabled us to keep working really strongly in partnership with them. So it wasn't just referring to our social prescribers, but there was something else that the social prescribers could refer onto for people who had internet access, email access. And then the offer that was there for me was I guided people in who'd not used Zoom before, you know, who were nervous. I had a couple of participants who had never used email before, and their families helped them set up email accounts just so they could access it. So I guided them in. I'd have them on the phone and I'd have the session up and I'd be guiding them in. And it, you know, it really opened doors. It gave, and one woman I did that to then probably joined up all 3 of the sessions, and it's also opened up for her that she's been able to have virtual consultations easier with her GPs for her other health conditions. So she was getting a more nuanced consultation than just over the telephone. So I really feel just so excited to have been part of opening that up for her. Let me just turn my page. As I've said, you know, we were concerned about the access about it. So we do know that it has excluded some of the patients that GPs would have liked to have referred to us. However, we have been able to provide a service, and I mean, one part of it is maintaining contacts with our existing instructors whom we didn't want to lose partnership working with, but also developing relationships with new partners. And the people who did attend the session, some of the comments that I've had back is one woman said it significantly helped her manage her diabetes because she was doing activity, and she said that she knew she wouldn't do anything on her own, and she wouldn't do just sort of a link onto a YouTube video. The fact that they were set sessions at a set time, we encouraged people to come along 15 minutes beforehand. The instructor stayed up for 10 minutes afterwards. So it kind of echoed what we had going on at Wellspring in real life, when people could stay on afterwards for a cup of tea and a chat. We had that. So someone talked about managing their diabetes better. Another woman said that her long-term backache was gone after one session of Caroline's living with chronic pain session. The woman who'd not even had email before said she made friends, and she didn't think she'd made friends through a screen, but because she went there joined beforehand, and we all chatted, and I went to every session at the beginning and did a kind of meet and greet and guided new people in. She said that she actually felt like she'd made friends, and she didn't think that would be possible through a screen. And someone who attended Qigong and living with chronic pain said that actually for him and his health conditions, living with chronic pain, that the virtual sessions were much better. Like if he had a choice, he would rather virtual sessions continued than real life ones, because of the way his pain manifests. He often couldn't get to Wellspring if he had a flare up, so then he completely missed out on a session. So we hadn't really anticipated that. I'll just finish off by saying that they've paused. I'm very clear that they have just paused because we want to continue them. So at the moment we're seeking further funding for them, and we'll definitely return to the ones where there was such a strong evidence base from the feedback and the numbers we were getting referred. But we're also seeking some new possible partnerships. I've got an idea around trialing antenatal yoga sessions, because I'm hearing a lot of evidence about women who are pregnant at the moment and how excluded they are from services they usually would get, and the massive impact that's having on their mental health. So that's sort of watch this space, watch the Wellspring website, I'd say. Thank you very much for your time. Look forward to your questions later.
Wonderful. Thank you very much, Subitha. I think you've given us some really good insight into some of the practicalities of getting people involved in these sort of different ways of delivering services. So thank you. I think now is a good time to take some of those questions, actually. We've had a few through the chat, which is brilliant. And please do post more if you want to as we go through. I think I'm going to start with a specific question for Jeremy, and then we've got some questions, I think, on a shared theme that I'll bring everyone in on. So the first question to you, Jeremy, has come in from Winsome Barrett-Muir, and this is about dementia. So it's asking whether across the studies you've been looking at the experience of people living with dementia and their carers, and the extent to which they've engaged in services. Is that something that AHRC's looked at?
No, it's not anything specific we've looked at across these different studies.
Thanks, that's helpful to know, Jeremy. And I think, Winsome, actually the Dementia Health Integration team are quite live to that issue and are keen to work with some of the other health integration teams to explore that a bit more. So perhaps we can follow up with you after about some of that work. So thanks for your question. We've then got one that I think all of our speakers might have something to pick up on, which was our first question really from John Hallowell, which was all about the struggle for the lack of human warmth and interpersonal connections that we're all really experiencing. So asking the speakers if they have suggestions for how we try and build that into health and care service delivery. I think we could start there with Stephen, because Stephen, you gave us a few reflections in your video about some of the things that were happening in other services to try and do that. So the photos of friends and family on the wall. Do you have any other sort of suggestions from your point of view that people providing services could think about in terms of trying to get some of that human warmth into what we do together?
Off the top of my head, no, but one funny thing I shall mention, this is about inpatient, that I was interviewing people about their experience for the stroke transformation program, and there was quite a lot of discussion about tablets and Facebook, and that being to some extent a barrier, but once it was overcome, it was better than nothing. And what did surprise me was that more than once somebody said, well, actually, I got so used to seeing the people that were looking after me in PPE, I couldn't see their faces. And it helped me when they went to the nurse's station or wherever, and we had a conversation over Facebook so that I could actually see them, over FaceTime, sorry. And it was that lack of a face. And the other thing that was mentioned several times was how helpful it was if you knew their names, and they need to be writ large, not just little badges. And all these little beginnings of establishing some contact, having no face but putting a name to it, those sorts of things, just gave them a little way into beginning to have a more friendly, more caring conversation. And I think this is possibly the case that goes on beyond that. And Bristol, after stroke, has been actually investing in more tablets and actually got a grant to buy some. And recognizing it's all distant and different, nevertheless, the power of the face has been something that's been mentioned several times.
Absolutely. Thank you, Stephen. That's really helpful to have those suggestions. I wonder then, Ali, if through your work with the chronic pain colleagues, have there been things that you've picked up that people are doing to try and replicate that, or at least get close to that sense of warmth that we get from face-to-face interaction?
Yeah, it wasn't a specific question that we asked, but certainly there was a sense within the data that it wasn't a huge barrier doing these things remotely. There's a question a bit later that talks about the difficulties of picking up the sort of nuances in conversations. But as I say, certainly from those services that were offering psychological support to people living with chronic pain, that there was suggestions from them that actually the interaction was enhanced because people were coming to them and they were less anxious and perhaps a little bit less guarded when being treated remotely. So actually that they were able to capture some of that warmth and provide that reassurance. I think one of the big issues at the moment is often warmth comes from touch, doesn't it? And, you know, just holding somebody's hand, which is very difficult at the moment, obviously, and very hard to replicate and impossible to replicate remotely. But, you know, if you can do something, and Stephen's absolutely right, just having a face to interact with and have that immediacy of discussion, I think that's at least going some way towards capturing and keeping that warmth within the interactions.
Thank you. Thanks, Ali. That's really helpful to hear. And then Subitha, are there things that you would like to add beyond what you've described already in terms of things that you think services can and should be doing to try and build that rapport?
And I think definitely having a person in a designated role like I was in, coordinating, setting up the sessions, so to taking the referrals, and sort of if I had time, I phoned people beforehand, but generally it was sent out. I would make email contact with them first, but sort of trying to build up a bit of a relationship and encouraging people, say, who were nervous. And then the offer to actually have people on the phone and guide them in. And with some people I offered to do a demo. So look, don't worry, no one's waiting on you for a session. I'll just set up a Zoom that's just going to be you and me, and making those kind of offers. So, making it clear to people we really wanted them there. And we knew that this was a bit of a glitchy and at times unpredictable way of connecting and offering a service, but kind of this is what we had to get on with. And definitely with our Zoom sessions, as I've already said, we encourage people to get there 15 minutes beforehand, and not just because of potential ICT nightmares, but actually because we'd really like to see you and we'd like to have a chat, but then we'd like to get on with the session because we've only got an hour together. And then there was also the conduit, and obviously people were living with long-term health conditions. You don't always want to divulge everything on a screen about, I'm particularly feeling a niggle here today, or I didn't sleep well for the past 3 nights. So there was always a way of emailing me or messaging me of something to communicate privately to the instructors, so they knew beforehand, without it having to all be on the screen. And for a lot of people, they couldn't use the chat because of, say, how chronic pain or their health conditions were affecting their hands. So that wasn't an option. So using me to communicate messages, I think helped that as well.
Brilliant, thank you. That's really, I can see some thumbs ups going on the screen, so thank you, that's great. And then Jeremy, I think just to sort of take one of the comments that we had that I think is very much on this theme from Jonathan Evans. So picking up that we're perhaps not that sure about what's being lost through all these digital interactions. I know you've done some work on some of the unintended consequences of digital tools. Is there anything you want to comment in terms of what evidence is there about face-to-face versus digital? That'd be really helpful to hear.
Yeah, I mean, the work I've primarily done is in GP practices, and there is a silver lining to this pandemic that now GP practices set up to do video calls when they weren't before. So a lot of technology suddenly rapidly had to be bought and installed. And what usually happens with GPs is they may start off with a telephone conversation, that then turns into a video consultation if need be. And from the previous work we've done, we found that remote consultations are good for certain things. So they may be good for simple inquiries. Where it's more complex or when something's new, it may still need a face-to-face. And there is the whole thing around holistic care, that are you doing a more transactional consultation? If someone asks for something and someone receives something, and missing something else, well, not having that person in the same room.
Thank you. That's really helpful, and perhaps after this we can share the link to some of that work, because I think it's really interesting. Brilliant. Thank you very much to our speakers. There are a couple of other questions for Jeremy. I think we might send those to you separately, Jeremy, if that's okay, and get back to the person asking the question, just in the interest of time. But for now, thank you so much to all of the speakers. That's been really, really helpful. We'd normally clap, but perhaps we can all just give you a thumbs up to say thank you. So thank you.